Hello, good evening. This is Meera from the Part 3 MRCOG Summit. This is going to be the next 30 minutes of discussion on the patient safety in the Part 3 curriculum. It's one of the most important domains, without any doubt. Most of the candidates are perplexed how to go about in this important domain as a beginner, and even people who have gone through for a few months of preparation, they might be apprehensive when it comes to, the welcome, Dr. Shruti. So they might be apprehensive when they think of the safety domain. Because to reach a sufficient standard for a pass, this is one of the most critical domains. And as you can see, the domains of healthcare laid out by the GMC, in those the domains, you can see that the safety domain is the first and foremost. How are we going to showcase this in our 10 minutes in front of the examiner, in front of the role player, in front of the lay examiner, in front of our colleague in the Part 3 examination, to be of sufficient standard to be a member of the RCOG? This is what we are going to see in the next few minutes. We are going to look at what are the principles assessed across all stations, the bird's eye view, and focus on safe clinical judgment, communication, and escalation in whatever situation we are given for that particular scenario in your station. And we all know that the knowledge alone is not sufficient for passing. This is Part 3. The knowledge is one of the most critical things in Part 2, and you have gone through that. And right now, it's about showcasing. Our agenda is going to be a little bit of introduction for the patient safety domain and what is the importance of patient safety in clinical practice. We are going to look at that. And what are the principles which are relevant to be showcased in Part 3 examinations? And common safety scenarios which you will be given for your examination, for your station, for that particular station. What are the common scenarios which you have to be thorough before you appear for the exams? Strategy. What is the strategy to demonstrate? Because it's all about demonstrating. As a clinician, I know you are all very safe in your approach. Given a patient, given a clinical scenario, given an emergency, you will be showing your utmost care for the patient. But how are we going to showcase this in front of the examiner? How are we going to verbalize how we think, how we act? This is what will be developed with practice, and that is a strategic practice. That is what you need to do every single day till your exams. And what are the assessment criteria? Because you all would have passed your post graduation. You might be practicing, you might be seeing clinical cases, but when it comes to these examinations, for the 10-minute period of time, they're looking at you and they're going to assess you for whether you are a safe doctor or not. And that is based on the domains and what are the assessment criteria that they expect, that they use to see whether you are a fit candidate. This is what is going to be our agenda today. Though most of the candidates, most of the doctors are fit clinicians, the key reasons for failure is one of the most foremost thing is the exam stress affecting the performance. Performance anxiety is a very rampant thing, and even if the best of clinicians can be perplexed on the day of examinations, going through 14 stations at a time due to new plays or not getting enough practice, or even practiced candidates, if they're not very confident, that stress puts you under. So, or of the often, even if they have the adequate theoretical knowledge, even clinical knowledge, if they're not able to showcase, this affects their performance. The key is to think that you are a clinician in your OPD. You are a colleague. You are a colleague. You are a person who is talking to a colleague, and the person sitting in front of you is just a colleague or a friend, or the one who is studying along with you. And the key is in understanding that it's just another step in our life. This is what is your strategy going to be. And one more failure reason is the inability to demonstrate. Sometimes, even if you possess those abilities, if you don't say it out loud, if you don't show it out loud on that particular day, you might be downscored. How are we going to go around this problem? By a structured approach, by a structured patient assessment, clinical decision making, and our case presentation skills, our communication skills, and a confident attitude. So these are the ways in which you can go about avoiding the key reasons for failure. I know this is overwhelming to see these all these CIP, the capabilities in practice, which I have put up. This is just to showcase, just to have an induction kind of thought for why we need to look into this specific domain. You can see that the professional identity and the capabilities in practice are laid out based on the healthcare professional, based on whether the professional is a researcher, scholar, educator, based on whether they are a clinical expert and a champion. You can see that in almost all these CIPs, safety is one of the most important domains. This is mentioned in the 14 capabilities in practice. It's a high-level statement setting out whether a doctor should be able to do at the end of training. This is what is given off by the college. So this is essential. And let us have a look at the clinical CIPs. There are various levels. You can see that the level 4 and 5 are in which a trainee or a doctor is entrusted to act independently with support or to act independently on their own. So with these things in mind, if you look at what a ST5 can do, you can see that they will be able to do almost all of the duties an obstetrician gynecologist is able to perform. You can see in the case of gynecological procedures, in addition to what ST1, 3, 2, 3, 4 are performing, you will also be looking at simple operative hysteroscopy, diagnostic laparoscopy, hysteroscopy, vulval biopsy. Okay, so all these things ST5 should be able to do. And in the case of obstetric procedure, a basic cesarean section, rotational instrumental delivery, these are the things which an ST5 can do independently. All right, so why do we need to know this? Because we need to have a stratification of when to call the consultant and how and when to manage by our own. Sometimes what candidates do is they'll try to involve the consultant for every single thing, thinking that it's showcasing their safety. It is not so, because involving the consultant for a simple basic step like an episiotomy repair or a diagnostic laparoscopy or just a diagnostic hysteroscopy, it is undermining yourself. It is not necessary, and it is not a safety behavior. So you need to assess the situation in which you need to call the consultant. Do not give it off that I'm going to involve the consultant as a blanket statement. How are we going to look at this domain here? When you look at a scenario which is given to you, or a clinical case given to you, or even a discussion given to you, as a clinician, you will understand that the demarcation between the domains is not a very clear one. There is no clear demarcation. You can see that the sea is merging with the land at some points. It's overlapping. The land is going into the sea at various levels, right? So there is no clear demarcation. But this is given off in points for assessment based on these domains, right? So at this point of time, you need to understand that this patient safety domain is an overarching frame over all the other domains. It is overarching towards information gathering, it is overarching towards the communication aspects, it is overarching towards your applied clinical aspect. This is what you will understand at the end of your preparation of the Part 3 curriculum. But at the beginning, when you are a novice and you are preparing just now, you're starting out now, right now, you need to look at what are the points which I need to say. What will be the points which will come under safety domain? You will start preparing this way so that by the end of your preparation, by the time you start your revision, the first revision, you will not be thinking in terms of domain. You will be thinking in terms of the clinical context. And your answers will come out domain wise. And your practice so far will help you score domain base. So that is how you need to prepare yourselves. Right now, just like how we discussed that it is overarching towards the other domains, let us see how the patient safety domain is overlapping with the info gathering. Because you are talking from the beginning, you are communicating with the patient throughout, or patient or you or the colleague throughout the station. And it's not like how you think at the initial point of time, that whether what I'm talking now is the information gathering. Now I'm talking with the patient about the disease, so this is communication. Now I'm going to tell the red flags, this is safety, and then I should be showcasing some applied aspect of it as to score in the applied clinical knowledge. No, it is not so. So what are the points which can come across as information gathering, but are there actually the safety points? So these are the things. Severe pain or heavy bleeding. The patient might be severely anemic. The patient might be in severe pain. You need to, catch this so that you will stratify the level of care. Sometimes the patient, immediate post-op patient, might be in severe pain. That is the case, you should not be asking the routine other history. You need to make them comfortable, give some painkillers, rule out some allergies before you go on to the further history taking, right? And if there is any heavy bleeding due to heavy menstrual bleeding and the patient is coming to you in the gynae OPD, you should not be overlooking the fact that she had been bleeding for some time and she is not a candidate who can be taken up for surgery in the immediate future. Her anemia needs to be corrected, right? So this is part of information gathering, showcasing your patient safety domain, right? Sometimes the patient might be showing signs of sepsis. The clinical scenario will give you certain signs of sepsis, which you would need to pick up. If you don't pick it up, you are losing on your patient safety domain, because understanding that the sepsis is a possibility, not thinking about sepsis is a grave error. Though this is coming out as an information gathering step, it is one of the most important safety step. And breathlessness or a chest pain, where you are going to think of in the post-op patient, it could be pulmonary embolism or even the cardiac ischemic heart disease. These are the things which are important to be elicited, which are going to be helping in your scoring of the patient safety domain, right? And in stations where, in modules where the blood group and reservation is essential, like the surgical or early pregnancy, where you will be asking about the blood group and any reservations for transfusion. If there is any reservation for transfusion, the safety point is going to be involving the consultant, documenting that they have the reservation, and making them understand that if they bleed more and if we are not able to transfuse blood, severe blood loss might endanger their life. So all these things will be incorporated into the safety domain. So even if you are eliciting these points, you need to showcase these things to make sure that you are at the level for a candidate who has passed the part 3. And take the example for smoking. If the patient is smoking, of course, you'll be adding up a risk factor for venous thromboembolism. You will be advising against smoking. You will be looking at the obstetric aspect of it, that the baby is going to be affected. What are your thoughts of quitting smoking? It doesn't stop with that. you have to arrange the next steps. If you wish to stop, I will help you with the reduction and eventual stopping by connecting you with the smoking cessation services. These are the things which will come under the safety point. And the mental capacity, which is very, very important when it comes to certain stations like the Alzheimer's disease station, or a daughter is coming up to the OPD with the information about her deceased mother who has the Alzheimer's disease, and she has some illness and she lacks the mental capacity, or sometimes her heavy menstrual bleeding in a girl who is young and who is also has the learning disability. This needs to be assessed. This is, even though it comes under information gathering, it's one of the most important safety points. And what is the assessment that you are going to do for the given scenario about the severity and stability of the patient, whether you are looking at the vital signs given in the candidate info, or you're asking for the vital signs, and how long she had been having these symptoms and how she has deteriorated. What is the hemodynamic status now? Or if it is all given, whether you are continuing to monitor this hemodynamic status, all these things will come under this principle. And always ask a focused obstetric and gynecological history. Do not go about the whole information, which is not relevant to the scenario right now. This is one of the most important things which is usually overlooked, because a candidate who is not very much flexible will be going on and on about these non-relevant things in an emergency situation. When a patient has come to the OPD or the emergency with acute abdominal pain or severe bleeding PV, or she is in the post-op with complaints of chest pain, if you don't consider that particular main concern, but you are going to ask about all the non-relevant things, this is something which we never do in our OPD, which we will never do as a clinician in our emergency, in our labor rooms. We will never do that. We'll not go about asking about whether you have taken your smears for a patient who is having chest pain, right? So don't do things, don't ask things which are not relevant at this point of time. So focused history taking is a safety point. And risk assessment, I'm sure you will not forget this. A very strong candidate who is very keen of passing will never miss the VT risk assessment, whether the patient is in sepsis or not thinking about sepsis. It's something a good candidate will never do. Safeguarding and domestic violence concerns. Safeguarding is important to think of when there is an abuse station, or when somebody, a patient has come to you with history suggestive of a domestic violence. She's showing signs of domestic violence and abuse. And if you don't say this point, it's a grave error. Make sure you never miss this. And to look at the signs, not spotting the signs of domestic violence is also a grave concern. So please look at what are the signs and spotters when you need to think of the abuse. And mental health concerns. When a person is coming with the depression, or who can go in for the mental health illness, if you overlook this mental health concern, it is going to be a problem. And make sure you don't ask this mental health concern for all the cases. Sometimes it might not be relevant. Don't ask about how have you been feeling so far for all the patients. Like when a patient is in labor, don't ask mental health history. This is not relevant at all at that point of time. And the drug allergies is something which is very important. Whenever we think of safety, this is something which will come to our mind as the first point to be mentioned. But that doesn't stop there. For example, if the patient has PPROM, okay, the patient has come up with PPROM, and she has, say, penicillin allergy. Your question, your safety aspect doesn't stop with just eliciting the allergy. If she has a penicillin allergy, you will ask the type of allergy, and that what happened previously, what is the type of allergy which you suffered, and that you will document it, and then you will go about, if needed, an alternative will be given. So all these things constitute the safety. Not just, okay, you are allergic to penicillin, just that eliciting and moving on. No, that is not how you do it. You elicit the type and you document it. All right. Any known allergies? That's how you will ask the question. Do you have any known allergies? And that's it. And clarifying missing critical information. This is something what is going on in the candidate instruction these days. They give you a lot of information in the candidate instructions. Almost most of the information are going to be given to you. And certain things which are missing out is what you are going to ask in the info gathering. Sometimes the patient, that is the role player, will not be giving out certain points. They'll talk about only their main concern, but eliciting these points are the critical points are going to showcase your safety. All right. So this is how we tackle the information gathering domain, the overarching patient safety. Now, how do we showcase this in communication? While we are talking to the colleague or talking to the patient, how are we going to showcase this safety aspect? By a structured and concise handover when we are discussing with the colleague. Let it be the gynae prioritization station, let it be the labor ward prioritization stations, or it's just a structured discussion. How you are conversing, how well practiced you are. You should not be just going on and on about what is already given to you. She is a 42-year-old coming up with a heavy menstrual bleeding, all those things. She has done all those things so far, and she is here with these complaints. This is not what we want to hear. We want to hear a concise handover, whatever is the situation. This is a patient complaining of chest pain in the post-operative ward, a possible pulmonary embolism. This is a patient who had undergone a hysterectomy a day back. She is 46-year-old and she is obese. And she had been on the oral contraceptive pills or HRT, whatever, and your assessment and what you want to do as the next steps. You are going to converse with the examiner in this format, in a structured format. And that is a safe behavior. Doesn't mean you are going to talk about, the situation is and the background is and my assessments are. No, this is not how. You incorporate this into your routine communication. And I actually work in a medical college. I have a lot of postgraduate students working with me. So usually what they say is when they come up with a patient in the OPD or even the labor room, what they say is, she is a 23-year-old, she is G33P1, L1A1, and she has had previous vaginal deliveries, and now she is 36 weeks, and so blah, 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 everything they will finish, and then they will talk about examination finding, and then finally they'll talk about the complaints. So by the time I come to the complaints, I would have forgotten her status. So start with situation. This is a possible rupture. This is a possible ectopic pregnancy. This is a gravida 2, para 1, live 1 in labor. She has had previous vaginal delivery and the pelvis appears to be fine. CTG is doing all right. And these are the next steps I would wish to go about. So this is how you need to talk in a clear manner. Accurate presentation of clinical findings and timely escalation to seniors. When you're talking about certain rooms in the labor room, sometimes this might be overlooked. Even if you will want to say that this needs to be by the consultant or you involve the consultant, sometimes this might be missed when you are overwhelmed in the course of the exam. So make sure you start with the people. Once you talk about the urgency and your next steps, the management, in the management stage, make sure you start with the people whom you want to involve and then talk about the next steps so that you don't forget. And you also are showing the necessary involvement, involving the colleagues at the start of the management. This is one of the tricks to not forget involving the colleagues. And clear prioritization of urgency. This is an emergency. This is my top priority. It's an emergency. Sorry, I know that you are overwhelmed and you are in pain, but this is an emergency and we need to act quickly. You need to tell this to the role player or the patient at that point of time to showcase your prioritization of the urgency at that point of time. That is a safe behavior. And closed loop communication during emergencies. Suppose you are in PPH structured discussion. This is something you need to mention. It's like a key word that this is how we will communicate during emergency so that certain things are not missed. And respectful multidisciplinary teamwork. And this is something which every one of us will say during our preparation time. We will involve the MDT, we will involve the MDT. It doesn't stop with that. Just the MDT is not sufficient. Just mention whom you will involve. This will be my multidisciplinary team. The people who will will be taking care of the baby, the specialist, the anesthetist, blood bank, and move on to the management steps. So the communication with the colleagues, you start with this as the management step and go on to the next steps of management. Make sure you document, you mention this documentation. This is something, again, when we are talking, we might miss it. Suppose this station is where you start with the referral letter. You end it with, I'll be getting back to your GP. I'll write back to your GP regarding our management, regarding your further steps, and I'll be documenting our discussion. All these things, and even in ST, when you are talking about the steps of management for a given scenario, documentation is something which you need to mention in your station. And what about the patients? When you're talking to the patients, how we are going to showcase the safety point? By explaining the diagnosis in a language that they are able to comprehend, right? And also the next steps in management, and not just the risks. We will try to, in our initial stages of preparation of the surgical module, we will try to emphasize on the risks more than the alternatives or the next steps of procedure. Risk is just an aspect of the information that they need to know. This is not the onus, the mainstay of your discussion point, right? So it's just an aspect. So talk about the alternatives. What else is her alternative for the treatment approach? And how are we going to go about the next steps? Explain all that and confirm concerns. Is that so? Anything else you want to discuss about? Is that your main concern? Can you tell me anything else you want to address? Make sure you have a to and fro communication throughout your role player station in order to not go about for something which is not relevant to the patient. If the patient has some other relevant concern, you did not give an opportunity for her to open up, that is a grave error. And discussing the warning symptoms and safety netting, you'll talk about everything. And finally, near the end, these are the red flags which you need to come to. The hospital will be giving you 24/7 contact number. If at all you have any of these symptoms, don't hesitate to contact us. Don't hesitate to come up. So this needs to be mentioned specifically. Obtaining valid informed consent, which we will practice in the consent stations. It is a whole process. And maintaining the confidentiality and professionalism. Confidentiality is again something which will come to our mind when we are talking about the safety aspect, safety domain, right? How are we going to showcase this confidentiality in stations, even stations where the patient has come out for abortion, right? And she wants to terminate her pregnancy, and or if she has fertility evaluation, or if the male partner has come to you and the fertility evaluation results are with you, you have to maintain the confidentiality. You should not be sharing the information. At the same time, sharing of information is essential in cases where you suspect abuse, or if you think that the patient needs safeguarding. At that time, you need to share the information. You need to break the confidentiality, right? So you need to balance that and show empathy while remaining clinically objective. As clinicians, I'm sure you will do this. So this is part of the radical framework, the previous old talk which you would have seen in your part 2 preparation. This is not much in vogue. This is very relevant. You can see that design for safety, if we think in terms of this, you can easily score well in the safety domain. By standardization, you should be knowing the basic guidelines protocols, which you are thorough because you passed your part 2. please don't go back and keep reading the part 2 things for a long period of time. Make sure you give time for the practice right now, strategic practice right now, so that uh, your time is not wasted. Effective communication in the form of SPR, crew resource management, care bundles. This is some thing which is like a key word. You have to mention certain care bundles: preterm care bundle, PPH care bundle, and the placenta accreta spectrum care bundle. These are the things which you need to say at the top of your hand, and whenever you are asked about it as a candidate who is fit to be a member, right? And how you're going to hand over. And I'll be debriefing my colleagues, and also I'll debrief the status to the patient. And so this is how you will go. Now, the operating theater safety checklist is something which you would need to mention in the surgical module, right? So something which you will never forget, WHO safety checklist. We will be following the WHO safety checklist. This is how you will mention it. So the assessment, how are we going to assess? How are you going to be assessed by the examiners? By the recognition of the red flags and clinical deterioration. Whether this said candidate is understanding that the patient or the role player or the scenario is showing a red flag, whether you're eliciting the red flag, we're looking for the red flag, whether you're prioritizing. Sometimes 4 or 5 rooms will be given to you. There will be an obvious room where the patient is collapsing. You have to go and ask that one first. I'll be looking into whatever is happening. In the room 5. There seems to be a possible PPH patient is collapsing. This will be my topmost priority. And even if the role play and the examiner is going to tell you that the patient has stopped bleeding now, it's all right. You will be telling that, yes, I will monitor. I'll send my ST3 or somebody, midwife, to monitor the patient. These are things which I will be asking her to monitor. And if at all she has any concerns, she will get back to me and go about the other rooms. There's nothing wrong in that. It's not going to take you off the course, right? So mention the prioritization, appropriate escalation and senior involvement when necessary, not for all. Safe prescribing and investigation choices. Don't be giving off investigations for all. Just the relevant things which you need to mention at that point of time. Risk assessment, like VT risk assessment. A patient is coming to you for early antenatal care. Look at the FGR risk assessment, whether she can go in for preeclampsia, whether she can go in for preterm labor. What is the risk? What is the background risk? Assess that and document it and follow it up. Mention those points in your management plan. Clear communication in handover documentation. And one of the most important things which might be missed is governance awareness. Whenever a scenario is given to you, and even if it can be an SPT, the clinical governance aspects are something which are most important safety points. At the beginning of a preparation, candidate will find it very difficult to how to go about the governance issues. But with practice, this is something which you can easily score, right? So governance aspect, whether you are apart from the clinical management, the clinical governance aspect is taken care of. Like if there is something wrong which has happened, whether you are doing the duty of candor, whether you are inciting an incident report, where you're looking at yourself, reflective practice, whether we are doing about the skills training and learning process about around this incident. So all these things needs to be mentioned in a station. Maintaining professionalism under pressure. This is something which is going to be there throughout your life, not just the exam, right? So maintain the professionalism even under pressure. The examples for a poor safety marks include missing the obvious red flags. This is not something which you would do. A candidate who is serious, they will never miss a red flag. So if such a thing is missed due to stress, then it will be ominous, right? It will be grave. So make sure you are at the top of your game. You are confident on that day of your examination, and that is only by strategic practice. Delayed escalation and safe reassurance. Sometimes candidates will go about and say a very positive thing for a patient who has, the omental cake in the ovarian cancer, the stage 4 cancer. They will be talking very positively that, yeah, you can go about the chemotherapy, fine, all that is also an unsafe behavior. Do not go about unsafe reassurance. You need to be honest. Ignoring abnormal observations is not something which you will do. Failure to prioritize urgent care. Inadequate communication during emergency. If you don't mention a particular name, like a consultant, that I will involve the consultant. If you forget, if you think you overlook that, it's going to be a grave error, because for that 10-minute period of time, they're assessing you. If you don't mention that, it means you're managing on your own. Not everything we will be able to manage by our own, right? It's a teamwork. So make sure you start your management steps with communication with the colleagues. And overlooking clinical governance points. Any station given to you, make sure you divide it into the clinical and the clinical governance aspect. So that way you will be able to finish off this in the 10-minute period of time. So these are the core principles assessed. Recognizing limits and escalation. As an ST5, we saw in the initial slides what an ST5 can do and cannot do. So if and when needed, are you escalating? You are recognizing, you're able to recognize your limits of competence, and you're escalating early and appropriately, and you're able to demonstrate the workforce safely under pressure. So this is what is this principle about. The confidentiality and governance, whether you are maintaining strict patient confidentiality, the Data Protection Act. Sometimes, for example, in a station where a patient is coming up to you and her previous data is lost or not there, then you need to understand that this is an incident needs to be reported, and you need to look into it. You need to mention that, I'm sorry, this has been lost. We will look into this matter. So right now, is it fine if I ask you some questions to know more about you? So that way you will be going, right? And appreciate implications of confidentiality breaches, like how we discussed before, when you can go and overlook this. Not essentially overlooking, where you need to breach for the safety. Demonstrate the duty of candor. This is something a beginner might find difficult, like how to apologize. They'll tend to apologize many number of times, and sometimes with an angry patient or a sad patient, they'll keep apologizing repeatedly. That's not going to fetch you more marks. It's going to make you look weak, right? So, straightforward, single, honest apology is going to help you as a professional and as a RCOG exam candidate, right? So apologize and practice on your apology so that it doesn't look very much overbearing. At the same time, it sounds honest, right? And avoid undermining colleagues. Just because you are honest and open doesn't mean you mention that this is the reason, the nurse is the reason, this doctor is the reason, this swab was left inside, and the GP doesn't know anything. Probably this is the reason why you have this discharge. So that's not how we are open. We should not be undermining the colleagues. You need to be diplomatic in answering the questions at that point of time. And consent and capacity. Obtain valid consent, respect the patient autonomy and confidentiality, understand the mental capacity principles. Right? In the case of a teenage, a person is coming to you and asking for contraception. Apply Fraser principles. That is, even if you don't give this contraception, the person can go on and have the sexual relationship, right? So if that is the case, you need to offer them the contraception. This is the principle. And even if a person who is underage is coming to you and she is understanding the implications of the treatment and the implications if treatment is not undertaken and the status of a disease, if she shows this much comprehension, the capacity, then you can go about saying that she is legally competent, and you can go about the treatment or the procedure. This you need to assess in the adolescent scenario. This you need to showcase. It's a safety domain. Recognize confidentiality rights in contraception and termination of pregnancy care. This also applies to the abortion practice, right? Something which is usually overlooked. Mention confidentiality in stations where abortion is the next step. And dignity, cultural sensitivity, and safeguarding. This is something which you will never miss. Like, for example, a patient who has had FGM. If it's not elicited. This is the core of that particular station, which any candidate will not miss. This is also a safety domain. Vulnerable adults and children. They might be from a minority. They might be an asylum seeker. Those are the safeguarding concerns which you need to mention. You will involve the safeguarding. I'll inform the consultant, safeguarding team. You need to mention that in the SPT or SD to showcase that you are a safe ST5. Mandatory reporting. Certain things you will need to report, right? This needs to be reported. I will report this to this. This needs to be mentioned. So all these things should come in practice. These are the principles against which you will need to showcase. Now, how are we going to mention all these things in the 10-minute period of time? Your